My name is Dr. Michael Hill. I am a diagnostic radiologist from the Department of Radiology at the George Washington University Hospital in Washington, D.C. And what I'm going to talk about today is the use of ultrasound in doing abdominal and pelvic biopsies. Now, the way I do biopsies is probably different than the way you do it, but I'm going to show you the way I do it, and maybe you'll get something from that. On the other hand, you may say, the way I do it is just as good, so I don't need your help. Thank you very much. So what I'm going to discuss is the use of ultrasound in guiding abdominal biopsies. And this is basically what I've learned over the years and how I do them. And as you're probably well aware, there are many ways to do a biopsy, and you probably have different opinions, but I'll share mine with you during this lecture. And by the way, I've no relevant financial relationships to discuss here. I would like to address your attention to the Ultrasound Quarterly article published back in December 2011, which does reflect the way I do my biopsy. So that would be a backup to this talk, which I'm about to give. First of all, when we are asked to biopsy anything within the abdomen or pelvis, we generally would review the clinical history and obviously the medications the patient's on, with specific reference to any medicines that might interfere with coagulation. We also have a biopsy form we have our clinicians fill out to give us the full clinical information on each of the patients. And following this, we will then review the imaging studies that are available. The questions we then ask ourselves is the biopsy indicated? Can I do it safely? And should I use ultrasound or will I need CT? In terms of the patient's coagulation status, we generally would do a hemoglobin, hematocrit, and platelet count, including a PTT, PT, and INR. And again, as I mentioned previously, we would also question the patient about anticoagulant medication. Now, this is a very broad subject, and unfortunately, I do not have the time to discuss what we do in our department, since every place has a different way of doing this. Again, I would refer you to the Ultrasound Quarterly article of 2011, where we do state our policies. Also, this article from AJR in 2009 is a very useful source where it does review the role of all of these factors when one is planning a biopsy in any given patient. And so therefore I would advise you to read this article so as you get some idea as to what other people do as well. Obviously, the risk of the biopsy is what's paramount in determining what you have to do if a patient is on anticoagulants. For example, we do thyroid biopsies with patients on all kinds of anticoagulants. It doesn't really worry us. But when we talk about doing a biopsy on an organ such as the liver or kidney, well, then we would want to have these coagulation, we would want to know the coagulation status of the patient prior to proceeding. Obviously, the risk of bleeding would be less as we go to doing lymph node biopsies or soft tissue masses, and even lesser so probably with doing a paracentesis or a thoracentesis. Now, why do biopsies using ultrasound guidance? Well, obviously we are in competition with CT, and we would like to use ultrasound if at all possible, since we have busy work days, and therefore, as we well know, ultrasound is a much quicker technique in comparison to CT. Not only that, but it is faster. It's faster, less expensive, and portable. Also, it's real time. You can go on any plane you want using a 5 to 10 megahertz transducer, depending upon the depth of the structure to be biopsied. However, as you well know, it's more operator dependent and does need a certain amount of skill. We also are out of business sometimes because we cannot see the lesion due to bile gas or bone, and in which case a CT scan guided biopsy might be more appropriate. In terms of whether we use a freehand technique or a guide, well, generally for small lesions that are superficial in location, we would tend to use a freehand technique, and for more deeply seated lesions, we would use an ultrasound guide attached to the transducer. In terms of what needles we use, well, first of all, doing cytology, we go anywhere from a 22 to a 25 gauge needle. We generally do these, at least in my practice, for cases where we suspect lymphoma to be on the diagnostic list. We will generally smear slides and put some into flow cytometry using RPMI medium. We will generally do at least 3 to 4 cytology aspirates, we will have our pathologist present to give us an idea as to whether we're dealing with lymphoma or not. Also, in some instances, we will use a coaxial approach. That is where we will actually use a 17 gauge coaxial needle. We will insert it down to the mass or the lymph node, and then through that coaxial needle, we will actually put a second smaller cytology needle at a 22 or 25 gauge size and put it into the lesion. We find this especially useful when we're biopsying deep lymph nodes because it does prevent the size of the 17 gauge coaxial needle does prevent the needle bending out of the field of view and makes it much easier to perform a cytological aspirate. In terms of core biopsies needles, well, obviously these are useful for obtaining histology. And we use these when we are looking at making a diagnosis of parenchymal disease, such as in the liver or the kidney, or diagnosing a liver or kidney mass or lymph nodes. As I said already, we use a 17 gauge coaxial needle and an 18 gauge cutting needle, and we will use anywhere from 1 to 4 passes and obtain core biopsy tissue. We can also vary the core length of the needle from anywhere from 1.3 all the way up to 3.3 centimeters. And I will show you where we use the longer 3.3 centimeter throw in just one moment. The automated biopsy gun that we use is easy to handle, gives an excellent core of tissue, and it produces a core of tissue with no crush artifact. Generally, we will put most of these core tissues usually onto formalin. However, sometimes when we are going to have the cytopathologist do a touch prep, we will actually put one onto a telfa pad, which is moistened with non-bacteriostatic saline, so as to allow easy detachment of the specimen from that telfa pad. And this is just an example showing you the automated biopsy gun that we used. You can see the well of the needle where the core specimen is obtained, and then in the bottom right hand side you can see an image of the core itself, and on the left bottom side you can see us shimmying the core specimen out of the well of the cutting needle. Now, the advantage of using a coaxial needle, which I've become very fond of, is you use a single localizing pass, and you can get multiple specimens by just inserting a second needle through the coaxial needle. You can also sample different areas of tissue just by manually changing the angle of the coaxial needle. In terms of patient preparation, I personally no longer use conscious sedation. I also do not have patients fast, and I also believe in the liberal use of local anesthesia. And I will use upwards of 30 cc's, which is the maximum dose of 1% lidocaine. Throughout the procedure, I try to reassure the patient, of course, at the same time monitoring their pulse and blood pressure, having obtained always proper informed consent, which includes describing the procedure and also its complications, including also the fact that sometimes we can't always expect to make a diagnosis using this technique. In terms of the procedure itself, well, we basically, having gotten permission from the patient, we will scan the patient. We will then choose an appropriate site to enter the skin to get our tissue. We will prep and drape that region, usually using either betadine or some other antiseptic agent. We will use ultrasound to guide the local anesthesia, and I will also use a 3mm skin cut with the scalpel blade to allow easy access of the needle through the skin. And again, as I assessed already, we also can use a freehand or a sterile guide technique. Now, visualization of the needle tip requires the highest frequency transducer that you can use, and we vary this usually from a 5 to 7 megahertz transducer. We obviously need to make sure we have the correct focal zone so we can see the needle tip. And sometimes the needle can be difficult to see, especially if the tissue is very echogenic. In which case, what I will do is I will rock the transducer back, I will rock the needle back and forth so as to visualize its tip. I will also use color Doppler, not only to visualize the tip itself, but also to avoid any intervening vasculature between the skin and the site of biopsy. I like to make a skin wheel using about 2 to 3 cc's of 1% lidocaine intradermally. I like to use a 3mm skin nick with a scalpel because this allows easy insertion of the needle. It will also allow you to feel the texture of the tissue you are going through. And as you know, a metastatic lesion in the liver is much tougher than the normal liver itself. So this sense of feel can be especially useful with small lesions in the liver. Okay, I'm ready to go again. Okay. The reason why I like to use local anesthesia along with ultrasound to get down to the organ to be biopsied is that you can actually see when you're entering into the muscle of the patient's abdomen. Now, as you probably are well aware, once you've numbed up the skin and the first centimeter or so of soft tissue fat, it doesn't really hurt the patient to go through the fat itself, but where it starts to hurt is when you enter into the muscle of the patient's abdominal wall. When you enter this portion of the abdominal wall, you should give the patient a warning that this will hurt. I also like to be able to insert my needle all the way down to the organ I want to biopsy, so I can put a layer of local anesthesia on top of, and in this instance this is the liver, so we would put a layer of a couple of cc's of local down onto this surface of the liver. For doing liver biopsies, we're obviously looking for either getting a piece of the parenchyma to evaluate for parenchymal disease, or we're going to be going after a mass to diagnose either hepatocellular carcinoma or metastatic disease. In doing the biopsies for parenchymal disease of the liver, I usually like to go in the supine midline subcostal approach into the left lobe of the liver. If the patient has a very small left lobe of liver, well then it may not be possible, and you may have to put the patient in the left decubitus position and use an intercostal approach. I personally don't like to use this approach because this approach hurts much more than going through the subcostal midline approach. Here we have an example on the left of using a 23 gauge millimeter thrown needle. And as you can see in this instance, when you can see the needle go into the liver, and you can see how far it goes down. In the old days, I used to do 2 biopsies like this, but then I went and used a 33mm thrown needle. And when you do a biopsy with this, you see you get a much deeper core of tissue, and you need only do this once. So that's why I like the deeper thrown needle when I am going after a biopsy for parenchymal liver disease. When I wish to biopsy a mass within the liver, I use a coaxial needle. I bring the needle tip down to the mass, and I like to biopsy, or I like to insert this needle through a cuff of normal tissue, and I'll explain why in just a moment. If the mass is very large, I will biopsy the outer margin. If it's a smaller mass, I will just go through the center. Obviously, in a larger mass, if one heads towards the center right away, you may just get back necrotic tissue, so we don't want that. So having once got the coaxial needle into place, I insert the cutting needle through the coaxial needle down to the mass. I then will suspend respiration, and then I will fire off the needle and withdraw. In this instance here, we have a patient with the history of metastatic breast carcinoma who has a small mass lesion in the liver here, and we're trying to make the diagnosis of whether this is a metastatic lesion. In the image on the left here, I did a fine needle aspiration, again by inserting the coaxial needle into the mass and then doing my fine needle aspirations here. And then I follow this with 2 core biopsies, again using the coaxial needle as my guide, thus emphasizing the use of the coaxial needle as allowing you to take as many biopsies as you wish with just one insertion of the needle. This is a patient with lymphoma, again with a small lesion in the liver, as we can see here. And then when we go to here, you can see the coaxial needle is here, and then you can see the fine needle being inserted through the coaxial needle to take a biopsy from this lesion, proving that this was in fact lymphoma. Now, there's always been a debate about whether you can do a core biopsy of the liver when there's a lot of ascites. And it's been well shown that the risk in doing a core biopsy is no greater whether you have ascites or not. It can be technically more difficult because of the fact that if you have a cirrhotic liver that is somewhat hard with a lot of ascites, it can be hard to get the biopsy needle into the liver. But even so, I rarely have to withdraw ascites to do this kind of biopsy any longer. Now this is an example of a vascular mass in the liver in a patient who has a cirrhotic liver and ascites. And here we have our ultrasound here showing the mass within the liver. And here we have our biopsy here. As you can see, again, I put a coaxial needle through the liver down to the level of the mass, and then through that I've taken my core biopsies to prove that this patient did in fact have hepatocellular carcinoma. Now, I don't like to biopsy lesions on the surface of the liver because of the fact, especially if they are vascular, they can bleed. And in this example, this was an HIV positive individual with hepatitis B with a cirrhotic liver and a vascular mass, very suspicious for hepatocellular carcinoma. So I went ahead and did my biopsy, and then following the biopsy, lo and behold, the patient bled, as you can see here. There's some blood off in the acidic fluid at this point, and obviously this demanded then he had to be embolized following this biopsy. So I learned a lesson from this, not to biopsy vascular lesions on the surface of the liver if at all possible. I would always try and make my way through a cuff of normal tissue. So the lesson I would have learned on this image here is that I would have brought the needle in from at an angle to this lesion rather than straight down to avoid biopsy on the surface of the liver, using a cuff of normal tissue to help you get a biopsy without having any bleeding complications. Now on to pancreatic biopsies. Well, as you know, we are in competition with endoscopic biopsies and also with a CT to do these types of biopsies. And I must admit that I don't do as many pancreatic biopsies as I used to do in the past. The reason is that endoscopy has taken over and is a very safe and effective procedure. In certain cases, however, if you have liver lesions, it's probably wise to biopsy the liver lesions first, because you will prove that the mass in the liver, let's say on a CT scan, is in fact a metastatic pancreatic cancer to the liver. And obviously in performing a liver biopsy, it's a lot safer than doing a pancreatic biopsy. Also, the other problem that you have in biopsying a pancreatic mass is that you often will have associated inflammatory changes with the cancer, which can prevent the accurate diagnosis of cancer among all these inflammatory changes. And as I said already, there is an increased rate of complications from biopsying these pancreatic masses in comparison to the liver. Well, if one has to biopsy the pancreas, for example, if an endoscopic biopsy has failed and you don't have liver metastasis, then I would obviously biopsy the head and body with the patient in the supine position. If the mass is in the tail, I would use the right decubitus position going through using an intercostal approach. In the supine position, sometimes it can be hard to see the pancreas because of the presence of gas within the stomach. So in that instance, I will actually have the patient drink some sterile saline and distend the stomach, and then use the water in the stomach as kind of a ultrasound window to the pancreatic mass. Again, making sure that you switch your color Doppler on to watch out for vessels, because these pancreatic masses often have small vessels on their surface, and you wish to avoid that and not have the patient bleed. This is just an example of a pancreatic biopsy using CT guidance. Now, we generally would only biopsy lesions that we deem to be unresectable, because if they are deemed to be resectable, then they should be surgically excised. Here's an example of biopsy of a large mass in the pancreatic tail. You will identify that I'm actually using the ultrasound to identify the stomach wall, which is over here, and the omentum, which is here. I would switch my color Doppler on, make sure there are no vessels in the omentum, and I will go through the omentum into the masses you see here, proving that this is a pancreatic cancer involving the tail. In terms of the accuracy of ultrasound or CT in providing a diagnosis of a pancreatic mass, it's pretty good. Actually, we make a diagnosis up to 95% of the time. Again, the complication rate is quite high at 2.6%. The rate is not as high in the liver, nor is it even as high in the kidney. Splenic biopsies usually have to be performed in the right decubitus position using a left intercostal approach or subcostal approach. If the spleen is big, we're generally going after a splenic mass, and the suspicion obviously would be it could be a metastatic lesion or a lymphoma. Again, in contradistinction to the theory that you should not biopsy a vascular mass on a liver surface, you can biopsy a splenic mass on the surface of the spleen. And I would reference the article below to make this point. In this instance here, we have a mass within the spleen, as you can see on the CT scan on the left, and then with the patient in the decubitus position going through the intercostal space, we can easily perform a biopsy of this lesion, again using a coaxial needle for obtaining FNAs and cores. Melanoma obviously is a lesion that can go to the spleen. In this instance, I biopsied this lesion, again with the patient in the right decubitus position. But unfortunately, following the surgery, the patient hemorrhaged and needed a transfusion. Coming on now to renal biopsies, again, we're doing it either for parenchymal disease in somebody with renal failure, or we would be looking at a mass in the kidney to be biopsied. Usually we have the patient in the prone position with a pillow underneath the abdomen to kind of stop the kidney from moving back and forth with bleeding, and also to make it more proximate to the posterior abdominal wall. Again, we like to use a subcostal approach. In some very obese patients where the kidney is very deep, it may not be possible to do the biopsy with the patient in the prone position, in which case I will actually put the patient in the decubitus position and then scan the upside and try and identify the kidney. Because when you do this, what actually happens is the kidney will actually move downwards and forward and actually will be closer to the skin in patients like this who are very obese. If that technique does not work, one may have to go through the intercostal approach, but that really I don't like to do. The other reason is if you use the intercostal approach, you often end up in the mid portion of the kidney, which always raises the possibility of the needle entering into the renal sinus, increasing the risk of bleeding. So anyway, when we are doing a biopsy for parenchymal disease, again, I will use my coaxial needle technique. I will bring the coaxial needle down to the capsule of the lower pole of the kidney, and I will obtain upwards of 4 cores. Obviously, again, I will have the patient suspend the respiration, fire and withdraw the needle, because obviously you don't want to be firing the needle off into a moving kidney. This is just an example of the scan plane that we would use to get down to the kidney. And this is an example of where we would fire the needle off into the kidney, right through the lower pole cortex. As I said already, you don't want to go up too high because you don't want to have the needle end up into the renal sinus where all the blood vessels are, which is obviously increase your risk of having bleeding in a patient like this. But bleeding does happen. Usually the hemorrhage from the kidney is usually self-limited, does not require treatment. On occasion, however, you may have to do embolization if the bleeding does not stop in a timely manner. So in terms of doing a biopsy of a renal mass, well, usually you're trying to distinguish, first of all, if the patient, let's say, has a lung cancer, and then you discover a mass in the kidney, the question always would be, well, is this mass in the kidney a metastasis, or does it represent a second primary, such as a renal cell carcinoma? Also, we biopsy renal masses when we have a mass in the kidney and a metastatic disease, where the patient would not be a candidate for a surgical removal of the renal mass. Also, we do biopsies of these small solid lesions that prior to ablation or focal resection. And there's also debate out there whether we should do Bosniak 2F or 3 biopsies, but that's a discussion for another day. Again, just like for the liver, when we have a mass, we take our coaxial needle, we insert it down to the mass, we insert the cutting needle through the coaxial needle and then fire it off after suspending the respiration. This is just an example of a large renal lesion, quite easily seen with the patient in the decubitus position, and you can see the lesion over here, where this is our plane of entry into the lesion, and we can easily do a biopsy. Here's another example of another lower pole mass here. Because of the size of the mass, you'd want to go towards its periphery, if you could, as we did in this case here. Another technical point here, as we look at this CT scan, we can see that this lesion is in the front portion of the kidney. It's got small bowel draped over it, and you can see that if we were to try and go from the back of this patient, we would end up going through the renal sinus and also through the pelvic calyceal system, which we'd want to avoid. So when we're using our CT scan in terms of planning our approach, we would now see that putting the patient in the right decubitus position and using ultrasound to approach him from the side would be the way to go, because in this instance you would avoid entering into the renal sinus of this patient's kidney. Now, adrenal biopsies nowadays are not very commonly needed because they really can be characterized as either being an adenoma by CT or MRI, or by being metastatic disease if they're a CT PET. Occasionally, however, we do end up with a case where we can't determine whether the mass in the adrenal is a metastatic lesion or not, or where it could in fact represent adrenocortical cancer. Obviously, we do not wish to biopsy adrenal masses that are pheochromocytomas, and so patients should be worked up appropriately to exclude that diagnosis if that is a consideration. And adrenal biopsy is again the same technique. Now, obviously, most of these lesions are small and cannot be seen by ultrasound, but if they are sonographically visible, it's quite easy to do a biopsy, usually with the patient in a lateral decubitus position. And here we often would have to go through the intercostal approach because of its position high above the kidney. Obviously, you could use a subcostal approach if it would allow that, and basically you have to angle up to avoid the lung and the liver if it's on the right side. In terms of retroperitoneal biopsies, again, you can have the patient in the prone position, supine or decubitus. Again, we're usually going after lymph nodes, either trying to decide whether they're Mets or lymphoma, or in terms of them being a primary retroperitoneal malignancy. One would like to obviously keep out of the way of the ureter to avoid producing a urinoma. Here's an example of a very large retroperitoneal mass, which I felt would be easy to perform by doing ultrasound guidance. So using my CT scan as a roadmap, I inserted the needle down into the lesion here. And I felt I had done a good job until the patient developed abdominal pain following the procedure. And upon doing a CT scan, because of continued pain, I found out that I had actually lacerated his pancreas and given him an extra pancreatic fluid collection, which actually required percutaneous drainage for a number of weeks. So that obviously wasn't a very good decision to make. I probably should have decided to actually do this biopsy using a CT guidance from the back, in which case I wouldn't have caused this problem. Now, in terms of peritoneal and mesenteric biopsies, again, we would put the patient in the supine position. Usually we're going after either omental implants or lymph nodes in the mesentery. We're actually pretty good at making this diagnosis, not as good as some things, but I think a diagnosis overall of 90% would be pretty good, with a minor complication rate of only 3%. As you can see in this instance here, we have a CT scan on the left demonstrating extensive omental caking in this patient with suspected carcinomatosis. And then when you put your coaxial needle in, you can do a biopsy of the peritoneum like this. Obviously, one would try to avoid bowel. I would also like to make a comment here. When you have ascites like this, you can actually see bleeding coming from the site of biopsy. And that happens in every patient, but usually if their coagulation status is normal, you won't have any trouble. Here's another example of a small implant. Again, using your CT as a roadmap. And this patient did have a history of lymphoma. And so we were trying to prove that this was in fact a lymphomatous deposit. You can see the image on the right here shows you that this is easily sonographically visible. And then on the next slide, we inserted the needle into this, an FNA into this mass, and proved that it was in fact a lymphoma of the omentum. Pelvic biopsies, again, we're trying to make a diagnosis of tumor, metastasis, or lymphoma. We generally will go through the abdominal wall. Actually, we can also put the patient prone and go through the sciatic notch if that's the best way to reach the mass. And again, I will be using CT to make this diagnosis. You can also do transrectal and transvaginal biopsies. This is just an example of a patient with lymphoma who has got some external lymph nodes that are easily seen on CT scanning, and were biopsied using an ultrasound approach. And again, I tend to, as I said, I tend to like to use the coaxial needle. We're getting here FNAs out of this lesion, and also we followed through with core biopsies. Now, in terms of doing transrectal or transvaginal biopsies, if I'm doing a transrectal biopsy to get after a lymph node or a mass, I will generally give the patient antibiotics 24 hours before and on the day of the procedure. In terms of doing transvaginal biopsies, you have to use probably conscious sedation, because these do hurt. And so therefore I tend not to do those myself, and I refer them to a colleague of mine who administers conscious sedation. In this instance here, you can see we are using a transrectal approach to biopsy a lymph node in a patient who had a prior resection for a rectal carcinoma, thus proving that this was in fact a metastatic lesion in this patient. Now, in terms of the post-biopsy care of these patients, we generally will keep patients for at least 2 hours of patient monitoring in our post-surgical unit. After 2 hours, they are discharged home with instructions regarding the resumption of their medications, especially this will be true of their anticoagulants. We also tell them to restrict activity for at least 5 to 7 days. And we tell them that the small nick in the skin, which we cover with a Band-Aid, can be left alone until the Band-Aid usually falls off, often in the shower. If, however, the patient after discharge develops any dizziness or severe pain, they are instructed to call us. And in fact, we do give them a phone number to call, which is a 24/7 number, so as we can take care of these complications ourselves if this should occur. Now, minor complications include pain. This is usually a self-limiting problem. Usually it's gone within 2 hours. It rarely needs pain medications. In terms of vasovagal reaction, I think the fact that we tend to let our patients eat before doing our biopsies, we talk to them and reassure them throughout, and that we give them a liberal amount of local anesthesia, has in fact reduced the incidence of vasovagal reactions. And I rarely now have a vasovagal reaction, whereas in the past I would have one of these reactions maybe every couple of months or so. Now it's a rare occurrence, so that's why I've gone to this way of doing biopsies. Anyway, if they do develop a vasovagal reaction, I just lower the head, elevate the legs, and wait. And I will give them IV fluids if needed. And I must say, I forgot to mention this earlier on, but we do have venous access in all of our biopsy patients should this complication arise. Now, major complications would be obviously doing a retroperitoneal biopsy would be a urinoma, which might require the placement of a catheter in the ureter. Peritonitis is a very rare complication, and in fact I had my first case just recently when I biopsied a patient who had mesothelioma, but it really is extremely rare. Obviously it's unfortunate when it does occur, and obviously one should try and avoid going through bowel, especially colon, when doing these types of biopsies. In terms of tumor seeding, I must say this is an extremely rare occurrence, and thank goodness I've never had this happen in my career. So in summary, ultrasound guided biopsies for me in the abdomen and pelvis are safe, they are accurate, and they're cost effective. My recommendations are you do not need to fast the patient, and you can use a liberal amount of local anesthesia and use ultrasound to make sure you cover all of the abdominal wall, so when you put the needle in, it will not hurt the patient. I also like using a coaxial needle approach, as you put the needle in once and that's it. You don't have to put it in many times. Also, it allows you to put a 22 gauge or a core needle through that needle and to do as many biopsies as you like without having to continually reinsert the needle. The other thing I would advise you to do is that over time you should look at your results in terms of your accuracy rate in getting a diagnosis in these patients, because obviously if your numbers are not up to that report in the literature, then you need to look for ways to improve your future practice. I've talked a lot about a lot of things here, so please see the reference list and the original article that I referenced for any more details. Thank you very much.